The purpose of this video is to provide you with the important information about the best surgical treatment for your condition. The reasons for considering having an anterior cervical discectomy infusion, or ACDF, is generally to remove either disc material or bone that's causing nerve root and or spinal cord compression and generally causing pain. Those problems can also cause weakness and numbness involving the extremity, the upper extremity, even all the way down to the hand and fingers. The purpose of surgery is to relieve those symptoms, most importantly the pain. The weakness and numbness also can be improved, although that's less predictable. The pain is most reliably relieved, and over 90% of patients get good or excellent relief of their shoulder and arm pain with this type of surgery. A smaller percentage, but still substantial portion of patients do recover their strength, and the numbness is the least likely to recover. With regard to the surgery itself, it's done through an anterior approach, meaning that the incision is on the front of the neck, usually to the left of center, something like this, and the surgery goes down to the front of the spine, and the disc is removed at the appropriate level, and once the disc is removed and the pressure is relieved from the spinal cord and nerve roots, then the next step is to place a small piece of bone, either your own bone, what's called autograft, or allograft, which is human bone from someone else, usually someone who's died from some trauma, and that bone is placed into the disc space, and then a small metal plate is attached to the front of the spine to help immobilize the segment so that the bone can heal, because the purpose of the surgery is a fusion, meaning that the two vertebrae, the vertebra above and below, will become one segment. So instead of two independent vertebrae, they will become one larger vertebra and be solidly attached one to the other. As I mentioned, there are two types of graft: either your own bone, which is autograft, which requires a separate incision over the hip. It's not your hip joint, it's if you put your hand on your hip, it's that hip. A small incision and a small piece of bone, usually about 7 millimeters, which is about a little over 1/4 of an inch, is required. That bone is removed from the pelvis and placed into the defect. This dark area here is the disc, and basically the piece of bone is fitted into a space about this size, and then the metal plate is attached to the bone above the disc space, and also attached to the bone below the disc space with 2 screws in each instance. If we use your bone, the advantage is it heals more quickly, and you don't need to be in a hard collar after surgery. You will be in a soft collar just for support and comfort. The downside to using your bone is it's your bone. So again, there's a separate incision, and it's painful. It does hurt, and it's difficult to get up and walk, particularly for the first several days. Usually after a week or so, the pain is improved substantially, but you may have some tightness or discomfort for 4 to 6 weeks in the hip. If we use bank bone, that comes from the tissue bank. Much like there's a blood bank, there's a tissue bank, and the bone is harvested from patients, again, usually someone who's died from some trauma. It's screened, it's processed, it's sterilized, it's packaged, and all we have to do is just open the appropriate size and place it into the defect. So it's, there's no second incision, there's no hip pain, there's none of that. The downside is that processing and sterilization removes certain important proteins and cells from the bone, and it's slower to heal. So typically patients are kept in a hard collar for about 7 to 10 days after surgery, which primarily is important because during that time you cannot drive. Most anything else you can do with the collar on. You can be up, you can walk, you can go places, you can do a lot. and your hip won't be painful, but you cannot drive. And for some patients, that's very important. This does carry some risk. There's two types of risk, really. One is the risk of anesthesia, which has to do with your medical comorbidities, things like high blood pressure or diabetes, age, other medical conditions, and it may be that you would need to have an anesthesia clearance in order to have surgery. The second type of risk has to do with the surgery itself. As I mentioned earlier, an incision is made on the front of the neck and the dissection is carried down to the front of the spine. There are important structures in the neck. These would include the esophagus, which connects the mouth to the stomach. It lays right along the front of the spine. The trachea or windpipe lays right in front of that, and both of these structures have to be moved or manipulated in order to gain access to the front of the spine. The carotid arteries, which carry blood to the brain, are in the operative field, as is the spinal cord and nerve roots. And so any of those structures potentially could be harmed. While that is a little scary for patients, it's important to realize that this is a very common type surgery. Most patients do very well. Complication rates are very low. Patients as a group do very well with regard to getting relief, and oftentimes these surgeries can be done on an outpatient basis even. One specific risk with anterior cervical discectomy and fusion is that the bone may not heal. We call that a non-union. One of the risk factors for non-union is if the patient smokes. For patients who are smokers or use nicotine products of any type, it's critical that they stop using any nicotine and stop smoking prior to the surgery. It may be that we check some blood work to confirm the cessation of smoking prior to surgery. Once the fusion has healed, nicotine use can resume, although obviously would not recommend that. With regard to the aftercare, or what to expect after surgery, as I mentioned earlier, a lot of times this can be done on an outpatient basis. In order to be able to go home the same day, obviously you have to be doing well, not having any issues with your blood pressure or any other sort of medical issues. Also, you have to be able to get up and walk. You have to be able to empty your bladder. You have to be able to at least drink and have your pain adequately controlled. And if all of those things are true, then generally you can go home that same day. Sometimes patients will have difficulty with nausea from the anesthesia, or difficulty emptying their bladder because of the anesthesia. And so again, you need to be prepared to spend the night, but typically you can go home. I do leave a drain in for the first 4 to 6 hours, and that drain would be removed prior to going home. With a successful anterior cervical discectomy and fusion, most patients will get very good relief of their arm and neck pain, and usually can return to full activity. Usually patients will return to see me in the office around 7 to 10 days after surgery, and can start its physical therapy with restoration of normal activities shortly thereafter. And long-term would expect no restrictions or limitations on your usual activities, even vigorous physical activities.